Welcome to this critical clinical explainer. Today, we're diving into something incredibly urgent, the stealth biology of pancreatic cancer. This is a devastating malignancy that systemically dismantles the aging body, and tragically, it often does so long before a definitive diagnosis is ever made. If you are over 60 years old, the information we are about to cover is a severe biological reality you simply cannot afford to ignore. We have to address this with the utmost authority and urgency because when it comes to this disease, early detection is absolutely the defining factor in survival.
To really understand how this biological threat operates, we're going to break down its destructive impact systematically. We'll be covering systemic and metabolic disruption, gastrointestinal failure, neurological invasion, advanced clinical markers, and finally, we'll outline a mandatory, life-saving, immediate diagnostic protocol.
Let's start right in with Phase 1, systemic and metabolic disruption.
Consider the absolute severity of this specific data point. Researchers estimate that up to 1% of individuals diagnosed with diabetes after age 50 will actually develop pancreatic cancer within 3 years. Think about that for a second. A sudden, unexpected diagnosis of diabetes in an aging adult, especially if you don't have typical risk factors like obesity or a family history, is an urgent, blaring warning sign. It demands immediate pancreatic screening, not just standard diabetes management.
The underlying biology of that warning sign is stark. Just look at the difference between standard type 2 diabetes and malignant new-onset diabetes. Standard diabetes usually involves a gradual insulin resistance that builds up over years. But malignant diabetes, that's a sudden, acute event. It's triggered when cancer physically damages or destroys the vital beta cells in your pancreas, known as the islets of Langerhans. On top of that, these tumors secrete substances like adrenomedullin that actively interfere with insulin function in other parts of your body. This combination violently halts insulin production and rapidly spikes your blood sugar.
This aggressive consumption of your body's resources leads to a severe condition clinically defined as cancer cachexia. Pancreatic cancer cells are metabolically ravenous. They release inflammatory cytokines that completely alter your baseline metabolism, forcing your body to rapidly break down muscle and fat stores just to fuel the growing tumor. This specific mechanism explains why patients experience sudden, unexplained weight loss of 10 pounds or more. It's a severe nutrient drain that aggressively continues even if you're eating plenty of calories. And the data shows this specific weight loss can start up to a full year before a formal diagnosis.
The crucial point here is recognizing the sheer scale of this metabolic energy crisis. Your body is fundamentally starved of fuel. You experience dangerous hormonal appetite suppression, meaning the hunger hormone ghrelin decreases while the satiety hormone leptin stays elevated. It effectively shuts down your natural urge to eat. Compound that with severe malnutrition from a lack of digestive enzymes, and you get an unrelenting, profound fatigue driven by anemia and systemic inflammation. This is an absolute energy deficit. Just sleeping or resting simply isn't going to cure it.
Now we move to Phase 2, gastrointestinal and digestive failure. One of the most visible biological bottlenecks here is biliary obstruction. When a tumor grows in the head of the pancreas, it physically compresses the common bile duct. This completely traps bilirubin in the bloodstream instead of letting it exit through the intestines. This backup causes jaundice, which you'll see as a distinct yellowing of the eyes and skin. Even worse, bile salts begin depositing directly under the skin, causing incredibly severe itching that can ruin your sleep, while all that excess filtered bilirubin turns the urine a dark, tea-like color.
Simultaneously, the patient suffers a complete upper digestive breakdown. When tumors block the pancreatic duct, those essential digestive enzymes can't reach the small intestine. This triggers intense dyspepsia, a persistent burning indigestion that people often wave off as heartburn. As the tumor grows, it can even compress the outlet of your stomach, causing severe nausea and vomiting of undigested food you ate hours earlier. Patients also describe early satiety, where they feel uncomfortably full after just 3 or 4 bites of a meal. And medical records show these specific complaints often appear 6 to 12 months before a definitive cancer diagnosis.
This total lack of digestive processing results in highly specific, visible changes in waste, clinically defined as steatorrhea. Without pancreatic lipase to process dietary fats, your bowel undergoes radical alterations. Fats pass through the body completely undigested, resulting in pale, greasy, distinctly foul-smelling stools that float. That foul odor is actually intestinal bacteria fermenting those undigested fats. You might also experience unpredictable, alternating cycles of severe diarrhea and constipation as the tumor physically alters your intestinal motility.
Which brings us to Phase 3,
neurological invasion, and referred pain.
These tumors don't just push against organs, they physically invade surrounding neural networks. The primary target is often the celiac plexus, a major nerve bundle right near the pancreas. When cancer cells infiltrate this network, they trigger a deep, gnawing pain in the epigastric region that patients frequently describe as boring or drilling. This is absolutely not a standard stomachache. It is a relentless abdominal pain that aggressively worsens right after eating, simply because the compromised pancreas is desperately trying to increase enzyme production against the inflammatory pressure of the tumor.
It is imperative that aging adults differentiate between common wear and tear and malignant disease. There is a massive, stark contrast between benign mechanical back pain and malignant retroperitoneal pain. Because the pancreas sits deep against the posterior abdominal wall, tumor pressure causes referred pain right in the mid-back. Unlike typical mechanical back pain that gets better with rest or stretching, this malignant pain is deep, it is constant, and it specifically intensifies when you lie flat on your back. It forces many patients to sleep sitting perfectly upright or in a recliner just to find temporary relief.
Moving into Phase 4, Advanced Clinical Physical Markers.
If those metabolic, digestive, and neurological signs go unrecognized, the disease progresses into systemic markers. A major, unexpected indicator is Trousseau syndrome. This manifests as an unprovoked deep vein thrombosis, a blood clot typically causing severe swelling and pain in the leg. Pancreatic cancer cells release high levels of procoagulant materials, like tissue factor and mucins, directly into your blood, tipping your entire system towards excessive clotting. A sudden, unprovoked clot, or a migratory clot that moves around, carries a severely elevated risk of an underlying pancreatic malignancy. And if those clots break free, they can cause a fatal pulmonary embolism.
During a clinical physical examination, a physician might detect what's known as the Courvoisier sign. This is a painless, palpable, distended gallbladder accompanied with that jaundice we discussed earlier. This finding is highly indicative of a malignant obstruction rather than common gallstones, which normally cause scarring instead of distension. During this exam, your physician may also detect a firm, irregular abdominal mass or a swollen liver.
But here is the truly devastating reality of this disease. Relying on physical exams to detect a mass is an incredibly dangerous strategy. Tragically, by the time a physical mass is palpable through the abdominal wall, 50% of all patients already have cancer that is metastasized, spreading through the portal vein directly into the liver. Waiting for a physical lump to appear is simply waiting too long.
And that leads us to Phase 5, the immediate medical diagnostic protocol.
Because traditional physical exams simply cannot detect this stealth cancer early enough, adults over 60 must adhere to these steps meticulously. Step 1. Log persistent symptoms. If you experience any of these overlapping systemic failures, indigestion, mid-back pain, profound fatigue, for more than 2 weeks, document them rigorously. Step 2. Demand a comprehensive evaluation. You have to bypass the over-the-counter antacids and push past routine physicals. Step 3. Request specialized, high-resolution CT scans, MRI imaging, or an endoscopic ultrasound. These advanced imaging technologies are the only tools sensitive enough to visualize tumors as small as 1 centimeter and unmask this stealth threat. I want to leave you with this highly provocative and potentially life-saving question. Are you fatally dismissing a critical biological warning sign as just a normal part of getting older? You need to evaluate your baseline health immediately. Recognizing the severe biological reality of these hidden symptoms and forcefully demanding the correct diagnostic imaging is the absolute only way to intercept pancreatic cancer before it's too late. Take command of your health right now.